Hi, my name is Dr. Tom Field, and I'm going to talk to you about anxiety. We have talked so far about the stress response system. We've talked about adjustment disorder. We've talked about post-traumatic stress. As a related concept to the sympathetic branch of the autonomic nervous system and the release of cortisol and adrenaline, we also have to talk about anxiety. Okay, this is another extension of that. It's another, in other words, cluster of mental health symptoms that makes sense within the context of the sympathetic nervous system. Here are the diagnoses that we're going to be covering today. We're going to be talking a lot more about these diagnostic criteria and a lot less about the sympathetic branch of the autonomic nervous system, since we've already covered that in quite a bit of depth. We will be talking about generalized anxiety, separation anxiety, selective mutism, specific phobia, social anxiety, panic disorder, avoidant personality, dependent personality, somatic symptom disorder, and illness anxiety. You'll notice here that we are covering personality disorders for the first time, a couple of them. We're also going to be talking about some somatic conditions that are also anxiety related. Okay, the reason for that is, in my mind, these are all captured as anxiety related problems related to the sympathetic branch of the ANS. Let's start by learning about potentially one of the most well-known anxiety disorders, generalized anxiety disorder. Okay, the code is F411. This is defined as for at least 6 months of duration. If there's less than 6 months, a person does not meet criteria. They have to experience excessive anxiety and worry occurring more days than not about a number of events and activities. The anxiety has to be difficult to control. Okay. Sometimes we call this, by the way, global worry or global anxiety. And they need 3 of 6 symptoms. This is one of the first times, in addition to PTSD, that we've seen some very clear guidance about how many symptoms a person needs to meet criteria or category. And as we've talked about in our first video lecture, I have a beef with this. A person can experience 2 of these 6 symptoms and still have a really significant anxiety problem. But I digress. Note that you only need 1 of these 6 symptoms if you are in childhood. Okay, so for adults, 3, children only need 1 of these. The first is restlessness, feeling keyed up and on edge. The second is feeling easily fatigued. The third is difficulty concentrating and mind going blank. The fourth is irritability. The fifth is muscle tension. And the sixth is sleep disturbance. And this is marked by difficulty falling asleep, staying asleep, and restless and unsatisfying sleep. Okay? Note that there are some clusters of symptoms here, right? Some of these have to do, for example, with cognitive aspects of anxiety, such as difficulty concentrating, easily fatigued, 2 and 3. Others have to do more with kind of restlessness, irritability, this kind of activation of the physiological system. That would be restlessness, irritability, even muscle tension, and sleep disturbance to an extent. Okay, so why is this? Why are those kind of 2 clusters separated? Well, think about it this way. If a person is sympathetically activated, they're going to experience all of those things: restlessness, right? Irritability, muscle tension. However, if they experience, too much stress, too much anxiety for a prolonged period of time, a person becomes fatigued, right? It weighs on them. It weighs on the body. And that's where you might see difficulty with concentration and fatigue occurring also during anxiety. When you're conducting a mental status exam, here are some potential signs of anxiety you'd be looking for in session. Okay, you'd be looking physiologically for fidgeting. This is marked by excessive motor movement, a flushed face, difficulty speaking. For example, a person may have difficulty just putting words to their experience and kind of stumble on their words. You may see controlling behavior. We'll actually look much more at that next week. We'll look at behavioral over-control. They may avoid tasks, topics, and eye contact. So avoidance can be a major symptom of anxiety. They may have cognitive aspects of anxiety, such as catastrophizing, rumination, and worry. They can also present as edgy or irritable with a superficial affect in terms of emotionality. Okay, so those are the things you're in general looking for And again, no one thing alone suggests anxiety. You're looking for a cluster of these things together. I'm going to share with you a couple of videos that give you some degree of demonstration of what these things look like. Restlessness, for example.
I'm not really sure if I want to get a new job. It's kind of scary. I haven't worked for a long time, and last job I had didn't really go that well because I didn't get along with somebody at work, and so I don't know. I've been giving it a lot of thought, but I don't think that it's going to be I don't think it's going to be a good thing to be doing right away. Anyway, I'm not really sure.
You can tell from the video that the person has difficulty sitting still. They have difficulty with just kind of, um, attending without movement, if you will, right? As part of their processing, they're moving a lot, they're touching their face, rocking back and forth. That's an example of anxiety, especially when talking about the content of anxiety. I'll mention that too. Note that the person was talking about worries about going back to work, and that's where you see the restlessness. So often with anxiety, you want to be assessing for the content of what they're saying in relationship to their behavior. Okay. All right. We're going to look next at the symptom of feeling keyed up, on edge, and irritable.
I got this exam coming up.
Let's try that again.
I got this exam coming up, and it's the last exam of the year, and I really need to do well on it. I've been looking at all the different things I need to do well for the exam, but I can't keep track of it all. I gotta, they're like essay questions, and then they're multiple choice questions, and then after the multiple choice questions, there's this big, long written thing. It's like 2 pages or something like that. I don't know if I can do that. I've never been able to write that well. I was talking to the teacher about it, and she's not giving me any help, so I got no help, and I got this gigantic exam to do, and a bunch of different things I don't know how to do. I don't know how I'm going to deal with it. I'm going to just drink lots of coffee and stay up all night and study, I guess. I don't know.
So in the context of the person worrying about an exam, they talk in a fast pace with kind of an edge to it, right? An edginess. They complain about the teacher not giving them any help, and so you get a sense that this person is worried, but in this kind of irritable, edgy way, right? And that's how they would present within a counseling session. They were keyed up. Okay, so we've learned about generalized anxiety, some of the symptoms, how they would show up in a session. So what do we do about it? So prevention, we would provide psychoeducation on healthy eating, sleep, and exercise, the pros and cons of worrying. This can be helpful because worrying, you should know, has an important function, right? It helps us to feel more prepared. So if we worry about something, well, at least we know what's coming, and we feel like we're ready for it. And so one of the things that I have often had to work with clients on around worry is coming to peace with, okay, you'll be less prepared if you worry. How do you feel about that? Can we work on that together? Because the consequences of feeling so prepared all the time is it really worth feeling prepared all the time? Is the cost worth the benefit? The impact of substance use sometimes can be something to attend to. Even something like caffeine can really ramp up anxiety. And then body awareness and mindfulness, right? Can a person become attuned to, aware of their own anxiety? Okay. So that's what you're doing to try to reduce anxiety in the first place. Note, by the way, that eating, sleep, and exercise do play a role in anxiety. If a person especially has not slept well, they're more likely to be anxious compared to if they've gotten a good night of sleep. And so sleep hygiene could be a major intervention. In terms of what we do in therapy sessions to address generalized anxiety when it occurs, we have several different options available to us. We could consider a CBT for cognitive restructuring, thought stopping, self-monitoring to help a client be able to kind of stop the worry, right? Reduce the worry, stop the catastrophizing. Existential, a person may have anxiety about things like death anxiety. For example, with COVID, this shows up really rampant, or their like life role, their life goals, what they're doing to address them. Sometimes a person may feel anxious, that they feel like just floating through life, right? That they don't have a direction. So helping them with that and meaning making can be helpful. Gestalt therapy, giving voice to the anxiety, helping them create almost like a character of it, almost like narrative therapy, really. And just give a voice to also what they're feeling in their body and just kind of talking through it that way. Solution-focused brief therapy using scaling and exceptions questions. So what do we mean by this? For example, with scaling. On a scale of 0 to 10, if, let's say you're at a 6 right now, what would it take for you to get to a 5? Exceptions questions, something like, when have you not felt anxious this week? What was happening? Right, and elaborating on that. Strategic family therapy of Jay Haley is a controversial one, but this is where strategic family therapy in a paradoxical intention is most used, is with anxiety, because it's a safer condition to use it with. The idea of paradoxical intention is to ask the client to exaggerate the current symptom they're having. So with anxiety, you'd say, I want you to worry as much as you possibly can in the next week and tell me what you notice. You couldn't do that for something like depression or suicidality, right? That would be unethical. But with something like worry, maybe it's safer to do it with, and so it's often used for this purpose. And I will say it does help clients become attuned to and aware of their own anxiety. Okay, we're going to move to a different diagnosis within the anxiety cluster now, separation anxiety. This is the most prevalent anxiety disorder for children less than 12 years of age. It decreases in prevalence with age as the child grows up. It is attachment related. You can think about this as attachment anxiety in a way. So what is separation anxiety? It's marked as symptoms lasting at least 4 weeks in children or at least 6 months in adults. Note that this can occur in adulthood, though typically we tend to think about this as more dependent personality, as we'll get to in a minute. It causes distress or impairment, and here are the ways in which the symptoms manifest. Distress when anticipating or experiencing separation from home or major attachment figure. Typically, the major attachment figure is something like a caregiver. Excessive worry about the loss of the major attachment figure. Excessive worry about event causing separation from major attachment figure. Staying home for fear of separation. For example, this is where school refusal comes into play. Fear and reluctance to be alone without the major attachment figure. Reluctance or refusal to sleep away from home. They won't go to, for example, sleepovers, or without the major attachment figure. Repeated nightmares with the theme of separation, and repeated complaints of physical symptoms with separation. Okay, so separation is very difficult, right? The person complains about it a lot. They won't or refuse to go to school, etc. Now, the question in your mind might be, how much of this is parenting, is behavioral, right, is learned behavior, versus how much of this is physiological? It's a complicated one. Sometimes it's both. But certainly the intervention for a separation anxiety is often behavioral, which is helping to kind of push the child a little bit and have the parents sit with the fact their child is anxious and be okay with that, versus cater to the child, which is often exacerbates, makes worse separation anxiety. So prevention, family systems work, reinforcing wanted behavior, right? You've gone to school, good job. Here's a sticker on your sticker chart. If you get enough stickers, you can have a prize. That's the token economy system. Extinguishing unwanted behavior, right? When you call from the nurse's office at school and say you want to come home, I'm not going to come pick you up. Okay. Quality time. So spending time at, for example, when the child is home with the child, so the child feels this sense of connection to the caregiver or major attachment figure. And then identification of supports, right? Maybe the school, for example, needs to be aware of this issue. Maybe there may even need to be something like a day treatment counselor within the school. And then intervention and treatment, cognitive behavior therapy, systematic desensitization, right? The person needs to be exposed to being away from the major attachment figure in order to overcome the anxiety. They obviously need skills to do that, right? They need to have the ability to regulate. Reality therapy, what's that doing for you, right? Is this helpful to you? And emphasizing choice. The reason this can be helpful is because some children of course, they actually worsen their connection with parents. The parent becomes more frustrated with them through their own kind of attachment to them, their anxious attachment. Or even they may experience something like they have to go into something like a detention facility if they're truant for too long, and they therefore are again removed from the parental uh, situation. And so, helping them understand that and getting what they want, which is parental attention and nurturance in a more appropriate way. Attachment-based interventions may be indicated, right? Parent-child attachment stuff. And then Adlerian parent ed, right? Maybe we might need to work with the parent on, how to address some of these behavioral challenges the child has, as well as, helping the child understand that their attachment to the parent is very normal. It's just the anxiety is a bit out of control. Okay, we're going to talk next about selective mutism and then specific phobias, two very different issues. Selective mutism is for at least 1 month, the person does not speak in social situations when speaking is expected, despite speaking in other situations. I'll note here that it's not that the person never speaks at all. It's just, for example, that they may only speak at home and not at school, or not when they're in the community. It interferes with occupational or educational achievement or social communication, and it's not attributable to language barriers, right? This isn't that the person speaks a certain language at home and they don't speak it at school, because they, for example, they speak maybe something like Spanish or Mandarin or something like that at home, and at school they're expected to speak English. It wouldn't be attributable to that. Okay, so that's selective mutism, and it can be, of course, a challenge in therapy because the person won't speak in therapy, and often you're doing kind of work with the parent and the child in the room or the caregiver. Okay, specific phobia next. There are a lot of different phobias. In general, what you're coding for here is at least 6 months of fear or anxiety about the object or the situation. This, this feared object is either avoided entirely or endured with intense fear and anxiety, and the fear is out of proportion with actual danger or social cultural context. Okay, so I'll explain what I mean by that in a second. Here, let me talk through a couple different types. Animal type, spiders, snakes. Natural environment, fear of things like earthquakes or lightning. Blood injection injury, so this would be fear of needles. Situational, that could be something like fear of heights. What I mean out of proportion with actual danger, by the way, is, if a person is, you know, cleaning windows on the Empire State Building and they develop a phobia about that, to an extent, is that really an unrealistic fear? I mean, you know, sure, it's impairing to them, but I think most of us would feel a bit freaked out being that high. But you're looking here for something that's out of proportion with actual danger, right? Another example would be a plane flight, right? A person may have a phobia of fear of planes, but that there's a very low rate of actual death that occurs on a plane, right? So that it's out of context in that situation. Social cultural context, what we might mean by this would be, for example, that let's say that you're in an environment where, I'll try to give an example of this. Where there's a specific meaning to things like an earthquake, or there's language that's often talked about around earthquakes. So, for example, if you're in, let's say, a fault line in California, and it's often talked about, and the people around you talk about this, then maybe you're going to develop a fear of that, especially if you had really significant earthquakes in the past. Whereas if you're afraid of an earthquake and you don't live in an area where that is something you need to be worried about, that would qualify for phobia. Okay, social anxiety disorder or social phobia. This is not what you think it is. I'll begin this with that right away. Okay, it is not just general social anxiety about being in groups of people and feeling shy. Okay, instead, it's a very specific type of anxiety. For at least 6 months, you have to have fear or anxiety about this is the important part, exposure to scrutiny in social situations, exposure to scrutiny, okay? So the person has a fear of being negatively evaluated, humiliated, embarrassed, or being rejected, and the fear is out of proportion with the threat. In children, this must occur with peers, not just adults, and there is a specifier of being performance only. So let me talk about the specifier. We often think about this as performance anxiety, that the person has difficulty with giving a presentation, let's say, because they're afraid of being, um, of being embarrassed or humiliated by that. But you can also see this in other social situations. So, for example, just being in a certain crowd or a gathering, but only if the fear is about scrutiny. If it's just a nervousness, a shyness, that doesn't count as social anxiety disorder. Agoraphobia next. For at least 6 months, this is fearful avoidance of difficult to escape situations in the event of panic or incapacitating embarrassing symptoms. We often associate this with panic. This used to be, by the way, diagnosed as panic disorder with and without agoraphobia. It didn't exist on its own. And so the way to understand this is, let's imagine a person has panic attacks and they're worried about being in a social situation that's difficult to leave where they have a panic attack. Okay. And that may lead to them, for example, having difficulty being, in public, using public transportation, being in open spaces or in closed spaces, standing in line, being in a crowd, and being outside of home alone. So you're looking for at least 2 of those 5 situations, and often the person may prefer the presence of a companion. Okay, panic disorder next. This is recurrent unexpected panic attacks. I don't know if I have the symptom profile on the next slide, maybe I do. And at least one attack needs to occur that is followed by at least 1 month of the following: persistent concern or worry about additional attacks, significant maladaptive behavior change, such as avoidance of antecedents or of things that could cause the panic attack. For example, an attempt to organize life around prevention of panic attacks. There is a performance only specifier, that these only occur in a performance situation. It just depends on the person. There are also some cultural issues with this, right? That there are different ways in which this can manifest in different cultures. And I'm not going to even try to pronounce these 3 things. Hit by the wind in Vietnam, attack of the nerves for Latin Americans, and then soul loss in Cambodia. These are different manifestations of panic that are more culturally related. So just kind of know that there are cultural issues that are similar to this, and you would not be diagnosing panic disorder if it was a cultural syndrome, if you will, if it was a cultural experience. I do have a slide on it. Look at me. So here is how to kind of understand a panic attack. These occur in the context of a lot of different conditions: anxiety, depression, PTSD, substance use disorders, medical conditions. In that case, if you do have, for example, depression with panic attacks, you would code it exactly like that. You would not have panic disorder as a separate um, diagnosis, especially if they do not develop these behavioral responses, such as the avoidance stuff, okay? The avoidance of anything that causes the panic attack. So it may be diagnosed as depression, major depressive disorder with panic attacks. Okay. If you do diagnose a panic disorder, you would not add with panic attacks to the other diagnoses. You don't need to. And you would do that again if there are like the behavioral avoidance symptoms occurring. So you're looking for a panic attack for 4 or more of the following, and these are all examples of physiological activation during sympathetic activation, right? Of adrenaline, for example. Palpitations, increased heart rate, sweating, trembling or shaking, shortness of breath, a smothering sensation, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, light, headed or faint, chills or heat sensations, paresthesias, which is numbness or tingling, derealization or depersonalization, this feeling about being out of body or things not being real around me, fear of losing control, going crazy, and commonly a fear of dying, right? That I'm having a heart attack, right? Or I'm having these pains in my chest, and that are a medical issue. And often people do present in medical settings such as emergency departments thinking they have a heart attack, and it's just a panic attack. Okay? So why does that occur? It's about physiological overactivation, right? And muscle tension that can occur as part of being that stressed, under that amount of anxiety, of sympathetic activation. So what do we do for phobias and panic attacks? Before I read this, it's very important that you kind of understand the difference between an adjustment disorder, between PTSD, and the conditions we've just looked at, which is generalized anxiety, separation anxiety. We've looked at phobias, mutism. We've looked at panic disorder. You'll note that unlike adjustment disorder and PTSD, there is a behavioral aspect of this, okay? So a person experiences anxiety and they are behaving a certain way in response to that. For example, with generalized anxiety, when they experience anxiety, they tend to worry a lot. They tend to overcompensate by, I'm going to worry about all future events so I feel prepared. That's a behavioral response. In separation anxiety, a person is going to cling to a caregiver, right? Because that'll help me feel less anxious. With a phobia, I will avoid any aspect or reminder of this so that I don't feel anxious. Okay? With panic disorder, I will avoid any situation in which I will feel panic. Okay? Those are just some examples, but you get a sense here that there's a behavioral aspect of these issues, not just the sympathetic activation, the physiological aspect. So we're often engaging in behavioral techniques here to basically help a person just sit with their anxiety, right? Just acknowledge it as just anxiety. That's okay, but we don't need to develop these behavioral responses, okay, to try to mitigate or control it. So often we're doing forms of systematic desensitization or exposure to kind of help a person approach, accept, look at their anxiety. So we'd identify triggers, create a graded hierarchy, and help them accept physiological arousal rather than just cognitively kind of prepare for it, prepare for the worst case scenarios. We also hope that we'll be able to change their perceptions of their arousal as a normal or expected situation rather than a problem, right? So for example, my chest tightness is to be expected. I'm not going to die, right? This experience is hard for me, but it will eventually pass. Those are things we want the client to lean into. Okay? To give you two quick examples of this with social anxiety, talent shows, things like that at school can be actually quite helpful for this, where you have everyone be very, very positive around this kind of sharing and presentations. Okay? If that happens enough, the person realizes that actually I don't need to be so worried about about a person's negative appraisal of me if I present, if I perform. And so setting up conditions, situations in which a person gets exposed can be helpful. Even if, for example, the person is just performing in front of their family and their family is very supportive over time, over and over and over again, that is helpful. With a phobia example, this is something I actually did clinically. I once had a child who was having nightmares and had a phobia of, believe it or not, Sasquatch. And what I would do was I printed off a bunch of at least 100 pictures of Sasquatch, most of which were very funny. It was Sasquatch performing a series of ridiculous activities, riding on a bike or whatever, silly things like that. And so I would just show them to the child, who was about age 8 at the time, and I would say, "Okay, real or not real?" Right? And he would laugh at the image and say, "Real or not real?" You just do it again and again and again, and then eventually the child realizes, Sasquatch is not something to be afraid of, right? So you can be creative here a little bit when you're doing exposure work. Okay, we've talked about anxiety disorders. We're now going to talk about a related form of anxiety disorder in cluster C, personality disorders. We need to first define what a personality disorder is. This is the first time you've been exposed to it. In the DSM-5, it is described as a pervasive, inflexible, maladaptive condition that is stable over time, causes distress or impairment, and begins by early adulthood. Okay? Pervasive, inflexible meaning it persists in all areas of a person's life. They behave like this in all aspects, not just at work, not just at home, all aspects of their life. Inflexible in that the person cannot change their response based on the situation that they're in. They always behave this way. Here, there are 3 clusters you should know about with personality disorders. Cluster A is the odd or eccentric cluster, sometimes called schizophrenia spectrum cluster. Cluster B is dramatic, emotional, erratic cluster, and you see this with kind of more conduct and behavioral issues. And then cluster C is the anxious or fearful cluster. Okay. Again, in the DSM at least, this is considered stable and thus untreatable. And one could argue, because this was in the same categories in intellectual disability in DSM-4, the personality disorders could be indeed considered a disability category. I think that's too strong, and I think it's kind of unfair that they're not reimbursed as primary diagnoses, because you can make progress with a lot of these, but that's just the way they're considered, so you should know that. The therapeutic goals are to cope with the resulting symptoms, usually, right? For example, with something like borderline personality, which you may be more familiar with, maybe the core fear of abandonment you're not going to change, but you may be able to change a person's anxiety, depression, paranoia, etc. So for a rejection example, and how you would kind of deal or make treatment plans based on this. So a rejection in the case of borderline personality may induce emotional dysregulation, and you'd work with the emotional dysregulation, right? That's the treatment goal. For narcissism, it could induce short-term depression, and you'd work on the short-term depression. Okay, so you get here the sense that you're still working on symptoms, right? Maybe the person's character, if you will, their personality is not something that they can change easily, but you can certainly work with the symptoms. You should know that some of the behaviors of people who have a personality disorder, some of their behaviors are considered egosyntonic, meaning they see it as part of themselves, not as something that isn't them that they want to get rid of. They may be annoyed, frustrated, distressed about the way in which people around them respond, but they may not see their own response as problematic. And distress may not directly occur as well. That you can sometimes have people who don't experience distress, just the people around them do. And that often also creates a problem with treatment and motivation for change. So let's talk about the anxious spectrum, cluster C. These are problems that usually manifest in interpersonal relationships. They're attachment related, marked by rigid relational styles, meaning they don't change relational style based on the situation and context they're in. You'll see an example of this in the 2 coming up. We'll start with avoidant personality. The way that Milan would capture this is the Theodore Milan, who's kind of one of the experts really in personality disorders. He talked about the difference between shyness, reticence, and avoidance. That was his spectrum, if you will, of avoidant personality. And so a person who has avoidant personality is exceptionally shy. That's the way to understand it. They experience social inhibition, inadequacy, and hypersensitivity to negative evaluation, like you would see in social anxiety or social phobia, but more exacerbated, more significant. They have fears of being criticized or rejected often. They avoid occupations with social contact due to fears of being criticized or rejected. They're unwilling to connect with people unless certain of being liked. They have restraint in relationships out of fear of being shamed or ridiculed. They have inhibited feelings of they are inhibited by feelings of inadequacy in interpersonal situations, especially new situations where they don't know a person. They view themselves as inept or inferior, and they are reluctant to take risks for fear of embarrassment. Okay? So you might imagine in a counseling session, this client would be very timid, right? And it may take a while for them to warm up. I'll note that on the graphic on the left-hand side, people who have avoidant personality may be much more comfortable over the internet communicating, and so you may see them be quite active in chat rooms and and have like quite a significant online friend community, and it's more difficult for them to have friends in real life. because when you're online, you have more of an ability to think before think through what you're going to say before you post something, right? And so you kind of can manage some of the potential for being shamed or ridiculed a bit better there. However, you do want a person to be making friends outside of the internet as well, and so that can be kind of using the skills they've learned to then translate them into real life friendships can be quite useful. Dependent personality. So almost like, again, an extension of separation anxiety, right? Just as avoidant personality in some regards was an extension of social phobia. Dependent personality is a need to be taken care of with clinging, submissive behavior and a fear of separation. Okay, and it's again more exacerbated than separation anxiety. This person has difficulties with making decisions without advice or reassurance, assuming responsibility for major life areas, expressing disagreement for fear of reprisal, initiating projects due to low self-confidence, volunteering. They have difficulty with volunteering for unpleasant tasks due to a need for support. They may fear being alone, and they may fear their ability to care for themselves. And they may have difficulty with tolerating single life after breakups and rush into the next relationship. You may see things like, with dependent personality, a person who, if they're in a relationship, their partner, say, goes out of town, and they call their partner once every hour or every couple hours to check in with them, right? It would be for their partner, they often feel smothered, stymied by this, right? That they have to constantly look after this other person. And that could initiate therapy, right? That their partner is struggling with it. So what do you do to address this in cluster C? So with prevention, recognize that each is a maladaptive coping response to anxiety, right? And that's where you see avoidance, that's where you see dependence. So you would teach coping skills for anxiety, right? CBT, DBT, mindfulness, those types of things can be helpful. The goal here is to accept anxiety and to cope with it. Interventional treatment for avoidant personality, you may want to focus on imagining criticism and the transference of that and helping them work through that imagined criticism. For dependent personality, you would want them to be taking the reins, right? To take leadership of counseling sessions to foster self-direction and autonomy. Person-centered is a great way to do this. Person-centered, by the way, is actually quite challenging for clients because they have to take the lead in sessions. And so that could be quite useful here. If you take the lead and you're doing more CBT here, you may miss the boat because the person needs to be able to take kind of autonomy, take charge. Okay, so we've looked at personality disorders that are aligned with anxiety. We did not cover obsessive compulsive personality disorder in cluster C. We'll cover that next week. We're going to next look at somatic anxiety. Somatic symptom disorder. What is this? This is another way in which we can have a behavioral response to anxiety. Okay? So this is excessive thoughts, feelings, and behaviors related to somatic symptoms or associated health concerns. You're looking for at least one of the following: persistent thoughts about the seriousness of symptoms, high anxiety about health or symptoms, and excessive time and energy devoted to symptoms. Okay? Severity is mild, moderate, or severe based on how many somatic issues. The timing, they have to become symptomatic, if you will, within at least 6 months. Okay, so if these persist for less than 6 months, it does not qualify. And you can have a specifier with predominant pain and also the persistent specifier of more than 6 months. Note here, it's important to qualify that a person can have genuine health conditions, okay? But this is not by itself going to account for the distress. Okay, so here's an example. Imagine a client has a minor myocardial infarction, right? A problem with the heart that results in the client's fears of making the condition worse, and so they don't leave the house, they don't exercise, right? They become disabled by fear. So this is all about basically how a person interacts with worry about their symptoms, right? And they have persistent worry thoughts about them, and they devote an excessive amount of time to those worries. Illness anxiety. This used to be called hypochondria. This is a preoccupation with having or acquiring a serious illness. Somatic symptoms have to be mild if present at all. Okay. And you see a high level of anxiety and hypersensitivity about health and excessive health-related behaviors, for example, checking every day for cancer. There are two different specifiers, care-seeking and care-avoiding types, with care-seeking being the frequent users of medical care. The duration has to be at least 6 months in duration. Okay. So with illness anxiety, the anxiety is very similar to somatic symptom, except the person does not typically have somatic symptoms to begin with, right? They are worrying about something that does not actually exist most typically. Whereas with somatic symptom, the person may have, let's say, something like asthma, okay, and then they worry a lot about the asthma that makes it worse. Where the illness anxiety, there's no asthma, but the person may worry that they have asthma, if that makes sense. Okay, factitious disorder next. This is commonly known as Munchausen syndrome, is how you may know of it. Similarly to malingering, there is no mental disorder. Malingering, by the way, is actually a Z code in the Z code section. The person is aware and deceptively presents themselves to others as ill, impaired, or injured. Okay. It's usually paired with treatment-seeking behavior. Differently than malingering, they do not have a secondary gain or motive. Let me talk about what malingering is. Imagine that you have charges against legal charges against you. You may, for example, claim to have a mental health condition in order to get those charges dropped, right, or to get a lesser sentence. Imagine that your employer is, you know, trying to discipline you for not doing a great job at work. You may say that you have a mental health condition to try to get out of that discipline. That would be an example of malingering, which is that you create a condition in order to have a secondary gain from it. Okay. With factitious disorder, what's interesting is there's no clear secondary gain, right? I mean, at most you could argue attention, but even that's not real clear. This person cannot be delusional or have a psychotic disorder, and the specifier single or recurrent episode. So this could look like, to give you an example, a person is absolutely convinced, 100% convinced, that they have it could be autism or depression, or it could be a medical condition, right? Such as, I don't know, multiple sclerosis, or etc. Right? They have a major medical condition that they don't actually have, and it's not real clear as to why they're saying they have this condition when they don't have it. Right? There's no obvious secondary gain. You will also work at times with families, and the parent thinks that their child has a condition they don't actually have. This is called factitious disorder on another, also called Munchausen's by proxy. The perpetrator, not the victim, if you will, receives this diagnosis. So meaning the parent or the caregiver typically would be the one with this diagnosis. And it can be quite difficult to treat because the caregiver typically is not interested in your feedback about it. I looked up my symptoms on the internet, and I'm worried that I might be dead. In the age of WebMD, the Mayo Clinic, the internet, there is so much access, right, to being able to look up this stuff, that worries about health concerns is only ramped up over the recent past. So what do we do about somatic anxiety? So remember that we have different behavioral responses to anxiety. This is one form of behavioral response, which is to imagine that you have somatic symptoms, or to worsen the somatic symptoms you have through your own anxiety. Okay, this is a form of catastrophizing, and so CBT is very useful here to replace catastrophic thinking about symptoms. Exceptions and scaling questions and solution focused are quite helpful. Tell me about a time when your symptoms did not bother you. How can we get you from a 7 to 6 on your worry scale? Gestalt therapy, giving voice to, If your symptoms could talk, what would they say? Psychodynamic symptom substitution. Have there been past traumas or events that are better, kind of capture why you're experiencing this anxiety in the first place? For example, did you have a major medical procedure as a child, right, that stayed with you? Okay, or are these symptoms you're having a distraction from another underlying issue that you have? And then existential, exploring death anxiety. A lot of this stems from fears of dying and helping clients to live life more authentically and to accept mortality, right? This that we all are going to die and there's nothing we can really do to prevent that, right? We just have to live the most fullest and best life we can. That can be a very powerful intervention for some clients. Okay, in conclusion, like trauma, anxiety is often linked to excessive neurophysiological activation, and the anxiety disorders also tend to have more of a behavioral aspect to them. You see this with PTSD as well, of course, the avoidance of thinking about memories of the event. But I think even more so in some regards in the anxiety disorders, you see these kind of behavioral syndromes that you have to intervene with. Anxiety has multiple symptom clusters, and you should just be aware of this, that there are multiple forms of anxiety. There's worry-based anxiety, there's behavioral avoidance, physiological anxiety, clinging to others, interpersonal forms of anxiety. There's cognitive anxiety, inattention, distractibility, emotional forms of anxiety, irritability. And you can also see cognitive distortions and form of thought related to this, catastrophizing, self-derogation. Okay? So because of this, we have to focus at the symptom level when we're working with anxiety, right? Because the word anxiety doesn't tell us much about what the client's going through. We have to get deeper into the specifics of what are the symptoms in order to correctly kind of identify the interventions, which should then be matched with the specific symptoms, the specific cluster of symptoms the client is experiencing. And that wraps this video lecture.